It's a wonderful pleasure to be here, and the first thing I say, it's a great crowd. What he didn't mention is I spent 2 years as head of the health sciences at the University of Minnesota. And when I went there, they said, Dr. Brody, there are 350,000 living alumni of the University of Minnesota in the state of Minnesota. So we would like you to, twice a month, go and visit to the give a speech to the different alumni groups. And since I wasn't from Minnesota, I thought that it'd be great if I just drive to these different places because it's a beautiful state. And so each month I would go to, every 2 weeks I'd go to a different alumni group. And in January, they sent me to International Falls. Now, I don't know, if you don't know Minnesota, International Falls weather is about like Siberia. And I was driving up there in a snowstorm. It was way below zero. It was a terrible day, and I showed up at the auditorium to give my talk. And this was 20-something years ago, so we didn't have PowerPoint. We had the carousel projectors. And I walk in, there's a room like this, and there's one person sitting in front, and there's a carousel slide machine projector. And so I look at my watch, and they said it's 8 o'clock, and nobody else shows up. 10 after 8, finally I said, is this the University Alumni Association? And he says, you bet, you betcha. That's how the Minnesotans talk. And I said, well, you know, is anybody else coming? He said, I don't know. I said, well, can I give my talk? He says, whatever. So I get up in front. I'm giving my talk, pushing the slides, and to get through my slides, he applauds. And I said, any questions? And he said, no. I said, well, thank you very much. And I walk over and pick up my slide carousel, and I start to walk out. He said, Dr. Brody, he said, you can't leave. I said, why not? He said, I'm the next speaker. So it's wonderful to be here, and I will have maybe this evening some remarks to say about Professor BR and the affiliation with the Technion and now with Rambam. It's great to be here. This is the Startup Nation, and everybody's telling you about the future of medicine. I'm going to tell you a little bit about the past because I went to medical school in 1966, which is really when the revolution in reducing heart disease began to pick up pace. And I taught an undergraduate seminar at Johns Hopkins when I was president called Uncommon Sense. It was about reasoning and problem solving in the real world, subtitled, Everything That Johns Hopkins Doesn't Teach You That You Need to Know. And so I'd just like to talk a little bit because when you look at historical developments, history is written by the victors, right? And so you look at how technology evolves and you learn about all the great things that happened and how Apple was so successful and Facebook. But they don't tell you necessarily about how they got there and how bloody some of the battles were. So I'm going to talk a little bit about that today. I happen to hold, until I'm now Emeritus, the Irwin Jacobs Chair. And Irwin Jacobs, of course, has been a benefactor of Israel, but particularly the Technion, and he gave $133 million for the Cornell Technion Consortium University, whatever you want to call it, in New York City. And in fact, he was, I believe, one of the people who suggested to Cornell that they involve the Technion. He's a wonderful, wonderful man, and he happened to be the chair of the board of the Salk Institute. In between 1965 and present, we've had this dramatic reduction in mortality and morbidity from heart disease, and we all look at this as a wonderful thing. But when it started, the established view was that heart disease was inevitable with age. It was just one of those factors of aging that occurred, and it occurred in men, that women were largely exempt from heart disease. And the idea that you could do anything about it was really an anathema to thinking at the time. And in 1940s, in fact, in 1948, the National Institutes of Health sponsored the first major longitudinal study of disease in a community called Framingham, Massachusetts, where they had 5,400 people who were enrolled in this study for decades, and now the Framingham study is in its third generation, a cohort of people. And one of the things they defined was the idea of a risk factor. Before that, there was no concept of risk factors. And of course, they identified a number of risk factors associated with heart disease. And if you look at what's happened since then, of course, there were a number of innovative therapies, both pharmaceutical or pharmacologic therapies, as well as interventional surgical and device therapies. And in 1996, there were 600,000, roughly, fewer deaths than occurred in 1963. And there's been an analysis of this, and I don't know how accurate the analysis is, but this was an article published in the New England Journal of Medicine, which said that about 47% of the decreased number of deaths was due to new therapy, both drugs, devices, surgical procedures, and the like. 44% due to reduction in risk factors, which may have been aided, in fact, by drugs like statins, and 9% unidentified. So it was a remarkable period of innovation. And really, the subtitle of my talk is about innovation. And although you all are associated with that as the exemplar of innovation, I think some people don't always realize that it requires several ingredients. The first, obviously, is creativity, which we understand. The second is perseverance. It's gumption, it's stick-to-itiveness, don't give up. And the third is luck, or serendipity, which makes it sound a little bit better. And ideally, you want luck of the good kind, but sometimes that doesn't work. There was a book published in 2012 in the United States by Stephen Johnson where he looked at where good ideas come from. And people always think that you have the aha moment. All of a sudden you have this epiphany and the good Lord comes down and says, Bill, you really should do this. Or you wake up at 3 in the morning with a great idea, and if you've ever done this, and write it down, and you wake up, and then in the morning when you get up, you look at the piece of paper, and it's completely unintelligible scrawl. You say, darn, I missed it again. But aha moments are really very rare. And in fact, most good ideas come from what he says, the edge of the possible. And oftentimes, good ideas are old ideas, but they're not possible to be done. And I'll just talk briefly about that. So it's really what he calls it it's the art of the possible, intersection of disciplines. So in my field, I trained in cardiovascular surgery. I went to the National Institutes of Health, and in 1973, they installed one of the first CAT scanners in the United States, and I said, this is a revolution, and we'll be doing things through images that we currently do through operations, and I switched into radiology and did interventional radiology. But the CAT scanner actually was an old idea. There were a number of people who thought about the idea of reconstructing a cross-sectional image of the body, but the technology wasn't there. And in fact, when the first CAT scanner was being developed by a British company, EMI, whose major claim to fame is they published all the Beatles records, they had to reconstruct the images, which were a very coarse 64 by 64 matrix. It took 24 hours to reconstruct a single image on a mainframe computer. And of course, today you can almost do the reconstruction on your iPad. They're instantaneous with high resolution. But it really required the intersection of computation, mathematics, and electronics to all make CT scanning possible. And in fact, when the CT scanner was developed, they went to the major X-ray companies at the time, GE, Philips, and Siemens, and tried to get them to market it, and they said, nobody will ever buy a machine like this. And so EMI went and started in the market, and they immediately sold out their first year of production as it became a revolutionary tool. But innovation is 10% inspiration and 90% perspiration. So there are a number of innovations in surgical and medical device medical devices that led to some of the decrease in morbidity, mortality from heart disease. And there are a bunch of them. I'm not going to go through all of them, but I've just listed them. And in almost every case, they were not ideas that were felt either to be possible or not ideas that were predicted. Although if you look before they occurred, there were certainly precursors that in retrospect were obvious things, but at the time didn't appear to be important. So I'll just begin with diagnostic imaging. Röntgen, as we all know, generated X-rays. He discovered them by accident, serendipity, because it blackened blackened film plates that he had, and rather than thinking that the film plates were contaminated with light, he actually investigated and determined that they had generated a new kind of wave called X-rays. And by 1897, there were more than 1,000 papers in print on the uses of X-ray imaging, which just goes to show that publish or perish was not a new phenomenon. And in fact, in 1897, Harvey Cushing, who became the famous professor of neurosurgery at Harvard, graduated from Harvard Medical School and came to Johns Hopkins for his residency and bought an X-ray machine. And the first X-rays at the Johns Hopkins Hospital were taken in 1897 with Cushing's machine. And of course, Röntgen was awarded the Nobel Prize in 1901. I think what people don't know is Röntgen was not the first person to generate X-rays. There were probably between 3 and 5 people who generated X-rays before Röntgen, including Hertz, the famous Heinrich Hertz, who discovered radio waves, but in the process was generating X-rays but didn't realize that he had done something different. And I think that's one of the key aspects that I'd like to emphasize in just a moment with a wonderful quote. The other thing that was interesting is that almost all of the major applications of diagnostic X-rays, except for CAT scanning, were predicted by people in those 1,000 papers, even though it took many years for them to become reality. And one of the things they did is they took mercury and injected mercury into the arteries of cadavers and took X-rays and showed the first angiogram, blood vessel imaging. It took another almost 50 years or so before safe iodinated contrast media could be used in people, but the concept of doing angiography was predicted well in advance. So my famous quote is, "Discovery consists of seeing what everyone else has seen, but thinking what no one else has thought." Albert Szent-Györgyi won the Nobel Prize in 1937, and if you look back at many major discoveries, they were oftentimes observations that multiple people made, but it took the unique individual, sometimes a crazy person, to recognize that this might be something different. And one of the things that I taught my students is that people who make major discoveries are the exception. First of all, they have the ability to recognize that something's different. But in addition, they have the courage to stand up to their peers who tell them, "That'll never work, that's crazy, why are you doing this?" And this is really a key feature of innovation, and it takes somebody that doesn't listen to what the herd says or doesn't care about necessarily what his or her peers are talking about. So there was a fellow named Alexis Carrel who in 1902 developed a means of sewing blood vessels together. Before he did that, people didn't believe that you could do anything if you had a severed blood vessel other than try to hold it and stop the bleeding. And he went on to transplant a dog heart into the neck of a dog. And later on with Charles Lindbergh, they built the first organ perfusion pump. So he really paved the way for open heart surgery, for cardiac transplantation, for kidney transplantation. He won the Nobel Prize in 1912, and some of his ideas were used immediately, but some of them, such as organ transplantation, took another 40 years again, before there was the art of the possible, before all the technology came together that allowed kidney transplantation, and then another 15 years later, heart transplantation. So one of the most important things for us in heart disease was the ability to demonstrate if you had heart disease, ultimately you had to be able to document what was going on. And that was the technology or the technique of cardiac catheterization. And the story in this case is about courage and reckless abandon. And I'd like to introduce you to a man named Werner Forssmann. He was a surgeon who did the first, what I call N=1 controlled clinical trial. And I'll tell you about it just in a moment. But Forssmann had this crazy idea that he could take a tube and put that tube in a vein in the arm. And if you look at the image on the left, he could take a vein and slide it up all the way into the heart. And so Forssmann went to his superior, the department chair, and said, "I'd like to do this." And the department chair said, "No way. Why don't you go and do this on animals?" But Forssmann was not deterred by that, and he decided that he would take matters into his own hands. So he went and asked a scrub nurse, a woman who was the scrub nurse in the operating room, if she would assist him, and he told her what he wanted to do. She said, "Well, sure, I'll be your volunteer." So he had her lie down on the operating table and strapped down her legs and pretended to anesthetize her arm where the vein is and cut down, but actually he was anesthetizing simultaneously. He actually was anesthetizing his arm, and he cut open with a suture, with a knife, the brachial vein, and he took a urology catheter, which, if you have any idea what current cardiac catheters look like, was a big bulky hose, and sticks it in his arm. The nurse realizes that she's not the subject, that he is, and she demands to be let go, and he does, and he says, "Look, would you take me down to the x-ray department?" So together, he's going like this with his catheter hanging out, goes down to the x-ray department. Under fluoroscopy, he pushes this catheter, and it goes all the way into the right heart and supposedly into the right ventricle, and cardiac catheterization was born. So what was his reward for doing this? Well, his chairman said, "You know, that's it for you." He bounced around. He was in multiple places. He wanted to be full professor, and actually Sweden honored him with an honorary professorship, but no German university would give him a professorship, arguing either that he was crazy and not trustworthy, or that he didn't have a PhD thesis of merit that would warrant his being a full professor. And he became, during the war, a Nazi, spent some time in a POW camp, and then ultimately went and practiced surgery elsewhere. But his ideas lay fallow for several decades until two cardiologists in New York came along, Cournand and Richards, and they read about his discovery. And then they spent 10 years exploring the potential of Forssmann's innovation for evaluating valvular and congenital heart disease. And subsequently, in 1956, the three were awarded the Nobel Prize for their discoveries in cardiac catheterization. And this was a seminal event because it now allowed physicians to really understand the actual state of the heart. So the next character in this, and again, I'm not evaluating all the things, just a few to show you sort of how the field evolved, was a loose cannon named C.P. Bailey. I don't know if anybody's heard of C.P. Bailey, but C.P. Bailey was interested in finding a treatment for mitral stenosis. He was a surgeon. And if you had an infection with a certain type of streptococcus, you were prone to develop what's called rheumatic fever, and with rheumatic fever, you would get, and I don't know if this is, I don't have my laser pointer here. you would get, you see the mitral valve is in white. The mitral valve would basically scar down, and the mitral valve sits between the atrium and ventricle, and it would narrow down, and the narrowing would cause increased pressure in the lungs, and ultimately that increased pressure would actually rupture some of the capillaries in the lungs, and patients would die from hemoptysis, of bleeding from the lungs. And Bailey had this crazy idea that he could operate on the heart without a heart-lung machine, and it was felt that if you actually cut an incision in the heart would, the patient would die. It was not possible to do it. But he had this idea of going into opening the chest, making a small incision in the left atrium, and putting your finger in with a knife on the end of it, and actually slicing the mitral valve to open it up. And it was called, the idea was a mitral commissurotomy. And so what he did was he signed up a group of patients who were end-stage mitral stenosis for this operation. And he did 5 patients in the clinical trial. They were probably given informed consent. And he killed the first 4 patients. And in the process, he lost his hospital privileges at least 2 of the hospitals. But he was undaunted, and he had a 5th enrolled, and he went to the 5th hospital and did that procedure at the Episcopal Hospital in Philadelphia, and the patient lived. And thus was born the surgical treatment of mitral stenosis, which was actually a fairly simple operation. And when I was at the National Institutes of Health, one of the surgeons there knew how to do this procedure. Even though we had heart-lung machines, he was able to operate on these patients without cardiopulmonary bypass. And it was a very effective procedure. Of course, today, cardiologists can do this with a catheter and a balloon that they put across the mitral valve and blow it up to dilate it. Again, for his great work, he bounced around a number of hospitals, was known as kind of a loose cannon, but he did continue his surgical procedure. But the mitral commissurotomy did ultimately took hold and opened up the idea that we could actually operate on the heart without immediately killing the patient. Another chapter in this really was the idea of how do we visualize coronary arteries, because if people were dying from heart disease, the largest amount of people were dying from narrowed coronary arteries or coronary atherosclerosis, but there was no way to visualize the coronary arteries, and so you had no idea how much disease somebody had or how much risk they were at. And again, the established dogma was that there was no way, not only no way to visualize it, and although by this time, angiography, the idea of putting a catheter into the heart, not into the heart, into the heart chambers or into the aorta, the major vessels, and injecting dye, you could visualize them. It was felt that if you injected this iodinated contrast material directly into the coronary arteries, the heart would stop beating and the patient would die. So nobody directly attempted to do coronary angiography. Next, there was a fellow named Mason Sones. I won't have time to talk about Mel Judkins, but Mason Sones was a cardiologist at the Cleveland Clinic. And he had a serendipitous discovery. He was passing catheters into the major artery coming out of the heart, the aorta, in order to do what's called an aortogram. And what he did is place the catheter in the aorta, and then you hook it up to a machine that injects this dye very rapidly, and you take X-ray pictures. Unbeknownst to him, the catheter migrated into the left anterior descending coronary, or the left main coronary artery. And when they injected the dye, sure enough, the heart stopped beating. And instinctively, he told the patient to cough. I don't know why he knew, and I don't know if you have any idea, Eric, but that coughing cleared out the coronary artery, cleared out the dye, and the heart started beating again. And thus, coronary angiography was born. And now we had a way of mapping who actually had narrowings of their coronary arteries from those who didn't. What happened then is over the next decade, Mason Sones at the Cleveland Clinic did over 1,000 coronary angiograms, even though people felt that that had no clinical utility. They said, well, you can do the coronary angiogram, but there's no treatment for it. But nonetheless, he persisted and had developed this wonderful library of coronary angiograms. In the middle of all this, of course, open heart surgery was well developed. It was used for valve and congenital heart disease. And there was a fellow from, well, let me just say one other thing I forgot to mention. Luck plays a major role in our discoveries. And as Louis Pasteur said, you can be lucky, but chance favors the prepared mind. Or as Michael Bloomberg once told me, Bill, the harder I work, the luckier I get. And it's not that, and part of it is if you work very hard in an area, when good luck comes your way, you have the ability to recognize good luck. Or you're in a position to take advantage of that good luck. So what happened next is a fellow named Dr. Favaloro, who came from Argentina to be a fellow in cardiovascular surgery at the Cleveland Clinic. And so he was doing his residency or fellowship at the Cleveland Clinic, and because his family was still in Argentina, he really had nothing to do in the evenings. So he went into this library of 1,000 coronary angiograms that Mason Sones had built up, and he began looking at them in the evenings. And what he noticed was that patients who had severe coronary artery disease oftentimes had it in the upper part of the artery, the so-called proximal part. And he came up with the idea of taking a vein from the leg called the saphenous vein and hooking it between the aorta and jumping over into the artery that was relatively normal after the narrowing. And he did this. He invented the coronary artery bypass surgery with no experimental results, with no dog studies or anything to do it. He just developed it, and within a year, this became the most common open heart procedure done in the United States and ultimately around the world. Again, it was somewhat of a serendipitous. Had he had his family with him in Cleveland, he probably would have been preoccupied in the evenings, but he had the opportunity. And had Mason Sones not continued doing coronary angiography, he wouldn't have the information. So this is an example of the use of data and predictive data to determine new courses of therapy. Another example is perseverance. There was a fellow named Charles Dotter. He was a radiologist at the University of Oregon Health Sciences Center, and he's known as the father of interventional radiology and angioplasty. Dotter was a tinkerer. He was a very cantankerous guy, and he didn't care what other people thought of him. And he developed a number of innovations in the use of catheters, both for diagnosis and treatment. And he did this in the early 60s and teamed up with one of his residents, Mel Judkins, where he actually performed dilatation of the arteries in the iliac arteries down in the groin, iliofemoral arteries, and showed that you could treat stenotic or narrowed vessels by angioplasty. But Dotter was sort of viewed as a lunatic fringe. Nobody took his work seriously, and that work remained fallow for over a decade. And then there was a German-Swiss cardiologist who learned about him. His name was Andreas Grunzig. And both Grunzig and Dotter demonstrated the difference between perseverance, which is standing up to criticism of your colleagues, and persisting, versus perseveration. Does anybody know what perseveration is? Perseveration, right, is what people who have dementia do. People with Alzheimer's will try to open up a door that's locked, never trying to actually unlock the lock. They'll just keep turning the knob. And it's a fine line if you are proposing something that everybody said is nonsense between being viewed as a pioneer versus being viewed as lunatic fringe. And it's this perseverance versus perseveration. And so the next idea that would never work was the idea of coronary angioplasty, that you could actually take a catheter with a balloon on the end, put it across an artery in the heart that's narrowed, and blow it up and dilate it. And this German physician, Andreas Grunzig, learned about Dodder's work, and he began developing balloon catheters in his kitchen. This was not well regarded by his German colleagues, so he moved to Switzerland, thinking that he would have a more receptive audience in Switzerland. And in fact, then he wrote a paper in 1975 that was presented to the American Heart Association, which was greeted with great skepticism. But fortunately, there was a cardiologist there named Richard Myler from San Francisco. And Richard Myler said, when it came up to him, said, you know, we could try one of these procedures on a patient who was undergoing open heart surgery for coronary bypass. So if there were any problems, the bypass surgery could still take place and there wouldn't be any, the risk of complications could be dealt with. So in 1976, with Dr. Myler, they performed the first human percutaneous transluminal coronary angioplasty, passing a catheter in from an artery either in the arm or in the leg into a coronary artery and blowing up the balloon and dilating this. I was at Stanford at the time, and my colleagues in cardiac surgery, who were great pioneers in what they did, said this was tantamount to death. This was a terrible thing that would never work. But nonetheless, Grunzig persisted, and a year later he got approval to do the perform the procedure in Zurich, and it was a resounding success. But everybody said, well, it works in one vessel, but you can't do it in multiple vessels, and most patients who have coronary artery disease have multiple vessel disease. But eventually, all of these objections were overcome. The early patients had to be done with cardiopulmonary bypass standby. The surgeon said, well, if you got cardiac surgery standing by, why wouldn't you just do cardiac surgery? But ultimately, there were other innovations that I'll talk very briefly about that allowed angioplasty to be done without cardiac surgery bypass, a backup. So the theme, really, if you look at all these things, is that the new technology frequently uses old ideas coupled with new innovations, whether it's computation or whether it's new materials, whether it's nanotechnology, whether it's genetic sequencing. These things come together and allow the art of the possible of something that perhaps somebody else had conceived of. In the case of angioplasty, Dodder didn't have the access to the materials to make the very small, supple balloon catheters, and so what he did would not have worked in the coronary arteries, but by the time Grunzig came along, there was a technology that allowed that to happen. Not all good ideas survive. How many people remember, you of course all know about the Macintosh, how many people remember the Lisa or the Newton? These were Apple devices that failed miserably. And innovation is always obvious. In hindsight, it seems like it was no big deal, and history identifies the winners, but oftentimes we don't hear about the losers. And in fact, before we had coronary bypass, we had a procedure, actually I scrubbed in on a couple when I was a surgery resident, called the Weinberg procedure, where you took an artery that runs inside the sternum called the internal mammary artery, you dissect this out, and you take basically a big pair of pliers, and you tunnel in a hole in a heart muscle, and you push this artery in there. And over 10,000 of these procedures were done. Some people thought it was wonderfully successful until somebody did a controlled clinical trial. And the controlled clinical trial consists of taking a group of patients with heart disease. Half of them had the Weinberg procedure, which required opening up the sternum and heart bypass. And the other half had a sham operation, which consisted of actually opening up the sternum. So they had a major operation, and it was closed back up, and when they did that, they discovered that there was no difference between the control group and the surgical group. I wouldn't have wanted to have been one of the patients in either group, but anyway. So, you know, how good are you at picking winners? And I like to use myself as an example of my great foresight. When I was at Stanford, we were hiring another person to do interventional radiology. And we got down to 2 final candidates. One was an established interventional radiologist from the Cleveland Clinic, and the other was a young assistant professor who was working at the Veterans Hospital associated with the University of California, Davis. And he was fooling around with some little devices. And I argued that I voted to hire the young faculty member from the Veterans Hospital. But in fact, we hired the fellow from the Cleveland Clinic. Now, there's no record to substantiate my position on this, but the person that we didn't hire was a man named Julio Palmez. Julio Palmez was the co-inventor of the coronary stent. And if you have an opportunity to go to Napa Valley to the wine country, Julio Palmez has one of the more spectacular wineries there. I was at Stanford University at the time, and I tell my Stanford colleagues that Julio Palmez could probably buy Stanford University today with his net worth. But really, our ability to pick winners is not very good, and there are many ideas that I said would never work for good reason, but didn't. But my predictions were wrong. And the other thing I would say to the young people is the experts are always wrong. And I teach people that wherever the herd goes, whether it's in investing or whether it's in innovative ideas, you really need to be a contrarian. And that means that you have to not listen to the experts. And Albert Einstein, of course, had this tremendous disdain for expertise, and he said, of course, fate made me an authority myself, so they punished me for being an authority. So I'd like to close with the 5 phases of clinical innovation, again, for the young people. So phase 1 is I develop an idea in my lab, and everybody says, this will never work. Phase 2 is I publish a study on the idea, and everybody says, well, it worked, but it cost over $1 million, took more than 10 years to do it, it'll never be practical. Phase 3 is, well, yeah, it worked in Dr. Brody's lab, but it's a specialized device, too expensive, not generally useful. Then step 4, it gets adopted widely, and people say, well, it worked in a number of labs, but it requires special expertise, it's not generally available. And then step 5 is it's ubiquitous. Everybody's doing whatever my idea was. And somebody says, yeah, it works. It was cheap and effective. But I came up with the same idea. I just never bothered to publish it. So I leave you with a summary that innovation really requires creativity, luck, and perseverance. And when you're going forward with innovation, it's a messy, difficult step. Difficult process. And history rewards the people that win, but oftentimes people who may have done something good get punished and disappear in the history books. New technology often gives new life to old ideas. And finally, the experts are terrible at predicting future outcomes. So with that, I want to thank you very much and for the privilege and honor to be here today. Thanks.